Well, thank you for having me. It's an honor to be here, and always great to meet the new surgeons coming up. I think one of the things we've talked about here is, here at this institution, we see a lot of cases that come in from the community that are revision cases that need to be done, kind of may skew our perspective towards, saying MIS surgery is not, the best option because you don't see the people out there doing well. You see the people that are doing poorly that come to you for a second opinion. As someone who does both, just kind of some of the tips and tricks and things to consider when you're looking at your patient population, whether they're appropriate for either surgery. I think something that has been valuable for me and, to really take into your own practice. I think obviously you want to consider that a lot of us have a pretty strong bias in our training, whether it's a very strong MIS approach or a strong open approach that your mentors have had, that can really guide your perspective going forward, and just to be mindful that there are benefits to both. Obviously, new technology with good reproducible data, if MIS is so much superior, why are we still doing open surgery? And, obviously there is data to support that, MIS is better, and it's really that blood loss, length of stay, and that's been consistent across a lot of studies. If all things are created equal, the patient is having, no statistical difference in this study in VAS and ODI at the final follow-up. So if you're looking 6 months, a year, 2 years down the road, people say they're equivalent. So what's the point? And you can keep the patient in the hospital longer, less, transfusions. If you multiply that across the hospital systems across the country, you're saving, tons of money and, hospital time and morbidity. So this was the just kind of the compiled aggregate data. And open versus MIS TLIF is the specific thing that we're looking at. And, obviously, if you look at blood loss and that's your main outcome, it's going to favor, but, it's not so strong. If you're looking at true outcome data, it hasn't been reproducible out in the literature. So some of the things, if you're looking at these studies and, some of them are very strong towards MIS data, are we really looking at the rates of arthrodesis? Have we followed them far enough to see that non-union? Are people using BMP or not? There's a lot of variability in how people treat MIS surgery. If you're looking at a lot of these studies and whether they had MIS versus open surgery, when I was kind of digging into these data, the people that were getting the MIS surgery had lower VAS scores in back and leg to begin with, because you're selecting the patients that are, probably doing a little bit better. They don't need as much. They're probably not in as dire strait clinically. So these patients may have been better off to begin with. So you really have to look at those kind of details when you're looking at these studies. And again, a lot of these come out of really high volume centers where people do a lot of MIS and that's their main focus. That may not be true for your average surgeon who's getting started or trying to add MIS into their armamentarium. It may not be the same outcome for them as it is in these larger studies. Laminectomy and laminotomy, I think, something to consider. It's not as well studied, but I think that, people that are taught traditional open laminectomy is one thing. Doing a minimally invasive, when I say unilateral laminotomy with bilateral laminoplasty, or you just using a McCullough retractor and doing a midline sparing decompression. So those are all technically the same surgery, but very different ways of approaching it. There are studies that say that those more limited approaches are better. And again, this is looking at a traditional midline full laminectomy versus a tubular decompression. I know Jens and Rod, how do you guys feel about the full open lammy? Is this something that people are still doing it, right? And it's still being taught. How do you guys feel about it?
should be an anachronism. I mean, we should learn from our MIS colleagues, we should respect the purpose of the posterior or dorsal osteoligamentous structures and only take what we need.
And Rod, I know you're doing a little bit more tubular decompression than you were in the past, kind of pendulum swinging. How do you feel about it?
Yeah, I mean, I try to leave everything intact if I do an open laminectomy. Try not to take the midline structures.
Yeah. You agree, Pat?
We do a lot of spinal stenosis surgery for older people, and we'll use unilateral, bilateral, just so we don't open the muscles on the other side. We do that with frequency, especially in the upper lumbar segment. So yeah, we're doing less invasive, standard old decompression procedures as well.
Yeah, and I would reiterate that, that's how, we like to teach it here. And, even if you're not familiar with tubular retractors and doing it in that technique, even doing an open laminotomy as opposed to a full laminectomy, you're preserving the midline structures, you're less likely to have that kind of post-laminectomy kyphosis that if you're taking that bone down and you're removing those ligaments. So things to consider as well. This is just a case, that patient did really well. Again, this is a percutaneous lateral. You can see getting a nice, that this was actually, I don't have the flex X views of instability at that level. This is great. Patient's very happy, but it may not be, the best for everyone. So if this is true that it works so well, why are we doing open surgery? Things like tumor surgery, getting a separation surgery, a lot of times people may have metastatic disease with compressive tumor. And we've seen some cases in our institution where, they tried to do a lateral corpectomy and percutaneous screws. That tumor was not taken off the anterior cord and, really didn't do much decompression, even though that entire vertebral body was resected. If you're not actually taking down the tumor off the epidural space, you're not getting the decompression, which is the whole point of doing it. And also your radiation colleagues, want that space, even if it's just a few millimeters, that you can take tumor away from the spinal cord. That makes the radiation that they're doing much more effective, and the patient's outcomes better. Obviously, major deformity surgeries, there are people out there doing it with MIS techniques, but really have to have a lot of experience, I would say, until you take one of those on. I haven't felt confident doing those yet. I think there are maybe some cases that I may try to do it in the future, but I've kind of stayed away from that currently. And, I think a lot of problems come from ankylosis if you're not getting a pre-op CT. Facet joints are fused and you're trying to get correction through an MIS approach. You're really not going to get it. So knowing your preoperative planning, and then obviously complex revisions can be pretty difficult. This was a case that came to me, and use of expandable cages I think is great. I like to use them. But if you're not doing it appropriately, then you're not getting that indirect decompression. So you can see here that this cage was inserted, and as you're opening up that expandable, you're hoping that you're getting correction of that disc height and possibly spondylolisthesis. But here it just went into the end plate, and patient didn't have any improvement in their outcomes. So the whole question about indirect decompression, there are people out there who don't think it's real. I definitely do. I'll show you a kind of image from this Nakashima study, which I think is a great one because I can't imagine getting funding for this, but they were able to do MRIs both post-op and sequentially throughout the first 2 years afterwards. And you can really see how well that indirect decompression is maintained. But again, I think it's highly relied on end plate preservation. Just like Juan was talking about with the lateral, I think that's true for any surgery you do where you're placing an inner body. If you're going to aggressively take down the end plate, you're not going to get the restoration in height. And maybe trying for less in a collapsed disc. If you actually get 3 millimeters of height as opposed to trying to put in a cage that's subsided and you're not getting anything, I think that's a huge difference in terms of outcomes. in these two cases, I'm talking about, didn't have a bone density workup, had osteopenia. One was an active smoker. These are things that you can control preoperatively. Not knowing that they're osteoporotic, not being able to treat their osteoporosis. And we have a great team here in endocrinology where, they are very aggressive about treating people preoperatively. And, the outcomes are better if you do treat the osteoporosis beforehand. I don't think there's any question in that. And I think these are one of those things that we should be making standard of care that hasn't quite made it out there. So this is the study I talked about. And, again, huge resources to be able to get, directly post-op 6 months, 1 year, and 2 year. And they actually showed in the study that not only in the direct post-operative period, but out to 2 years, when you have that stretch of the ligamentous complex, not only is the disc space, but the ligamentum flavum actually gets smaller over time when you can restore that anatomic height. So I definitely, obviously, it's the reason that these surgeries are successful is because indirect decompression is real. I think all of us have a different cutoff for how much we're going to rely on that, especially if you're not getting post-op imaging. Just some anatomic considerations here. This is kind of a traditional approach for an MIS TLIF. That's like a more of a straightforward bullet type of cage. If you are in a case where you have cage subsidence, there is the option to switch to more of a kind of banana-shaped cage, and getting this bone here in the center of the body is much, much weaker than, looks like I lost my images, much weaker than that apophyseal ring. So if I am doing an MIS type of approach, I try to use that, getting that cage anteriorly, getting a wide cage that's on that apophyseal ring is going to give you a lot more stability as opposed to something that is in the center where there's more risk for subsidence. So again, we looked at this case before, and post-operative radiculitis, I think, is another thing to consider. It's something that I rarely ever see in my open cases, but in MIS TLIF, having that discussion with people that having a post-op radiculitis is something that is it's very well described. It's not very common, but the people that have it can be very unhappy. It's hard to know whether it's the technique, whether you are coming in through that Camden's triangle and irritating the nerve directly with your instruments. A lot of people that do MIS TLIF use BMP, which can cause hypertrophic bone in the foramen. Can also be, just the BMP itself can cause irritation of the nerve root, so it's something to consider. And then this is just looking at a study that actually looked at that. So if you're looking at MIS versus open, with and without BMP, that odds ratio for having a post-op radiculitis is, over 2 times greater. I don't know if it's one or the other. It's probably a combination of both, but it is a discussion you want to have with your patients if you are going to use that kind of approach. It's another case here. 54-year-old who had worse radiculopathy after the surgery. I think the surgeon looked at this and said, looks fine, you'll get better, and kind of brushed her off. So, in terms of technique, I was concerned about that bone in the foramen maybe causing a problem. On closer look, if you look at that screw is in the foramen, so that's never going to be a good sign for your nerve root coming out there. So, taking these patients seriously, you may not see it. Obviously, this is a pretty, straightforward example of having something that has been, a post-op complication. But these patients may come to you, and that's something that's very simple that was just not discussed with the patient in their post-operative course. So, we revised this. We took down that bone. This is a very kind of challenging case, going into that scar tissue, taking down that heterotopic bone, replacing that screw, but she was actually very happy and had resolution of her radiculopathy. Another thing that I think is something that is, I'd love to hear if Juan's in the room, whether he thinks this is something that we should do. I've been afraid of it, but standalone laterals, these patients can be very happy, but there is a pretty high subsidence rate. Not all subsidence causes recurrent symptoms, especially if you're doing a level above a prior fusion. It can be a very nice way to address adjacent segment disease. And it significantly reduces surgical morbidity if you're talking about extending a fusion up, doing an open posterior approach, and doing instrumentation, as opposed to coming in and doing a single level lateral, which can be, a great way to reduce blood loss and morbidity of surgery. So I don't know if we can get some thoughts from the crowd. So this lady has had multiple surgeries, obviously, had a standalone lateral above her 4.5, still had symptoms. The recommendation, I think it was a left-sided lateral. The recommendation was to come back and do a right-sided lateral inner body. Any thoughts on, whether this would be appropriate or not? Anyone do standalone lateral? Yeah, obviously this is, in the setting of deformity, I think it's probably a pretty strong contraindication. But, anybody seeing standalone laterals that's being done, I know it was kind of put out there at the beginning when lateral was coming out as something that was appropriate. But
Hey, it's Dave at Okonkwo. I don't know if you guys can hear me.
Yes.
Dave, thanks for chiming in.
Yeah. I'm sorry I couldn't be there when the NFL schedule came out and the Steelers got one of the Friday night slots. There was just no way for me to be in Tampa yesterday, and as well as Seattle. So I'm really sorry I'm not there. This is my favorite course of the year, and miss you guys. I'm sorry I'm not there. I think that the era with 3D printed porous titanium implants has meaningfully changed the game for standalone laterals. And we were, the folks that were publishing those reports back in 2009, 2010, and 11, saying standalone lateral in the setting of deformity, you have to be very careful about that because of the high failure rates. But in the modern 3D printed porous titanium era, this is becoming a meaningful part of my practice. It's still a very small percentage with a very targeted patient population. But I think the technology has caught up with the vision of the early adopters from 15 years ago. And our current technology actually allows us to address cases just like this with standalone laterals in very specific instances.
Thank you for that input again. I think that it's something that, I've seen it done well. You see the failures that come to you, but I appreciate that because, again, it really is something that I think could be very valuable in the right setting.
I have a question. So the Nakashimi study showed very convincing and nicely done serial MRI scans, which in our healthcare system is just not even remotely possible. But I want to point out that there was an important subtlety, which in our undifferentiated approach sometimes, where one size should fit all, we miss. All those patients had ligamentous flavum hypertrophy. None of them had primary substantial bony hypertrophy. So back at you, Dave. So if you have a patient with primary significant bony facet hypertrophy, can you even remotely expect to have even the nicest 4D printed, I'll up you, 5D printed, microfilamented, negatively charged, whatever stuff you want to throw in there, cage? Can you remotely
nanoscaled implant.
Nanoscaled, yeah. Piezoelectrically active cage. Can that actually do a meaningful indirect decompression if you have a profound bony hyperplasia,
No.
anything like that?
No, and I was recently a visiting professor, and the residents had some really, really wonderful questions along this topic. And in my opinion, you have to be very careful about that concept of applying pure minimally invasive approaches to the patients with neurogenic claudication, in particular when that neurogenic claudication is a result of facet overgrowth, facet arthropathy. It's those patients that have the soft ligamentum flavum hypertrophy, though, that can respond favorably to that. So you have to understand the patient's presentation, the patient's symptoms in relation to the patient's imaging in order to do your best at making a good diagnosis and formulating a good plan.
It's great to have you, Spice, here. And Jim in the back is really missing you. We are missing the Philly versus Pittsburgh Sparks.
I'm sorry. I'm sorry.
Okay.
Blame the NFL.
So next question, point of contention. When is enough enough? So I have a practice riddled with patients who've been, I don't even know the number, I'm making that up, but not less than 5 surgeries. You have them, 5 surgeries, and they've had a stackable MIS back, then MIS side, then MIS back on top configuration of fusions that have left them relatively flat usually. And then at around L2, they stop, and they are literally looking like they've been Uzi'd. So they've just been riddled with incisions front and back. And then they come to us, and guess what? They get a big whack. But is there something where we should just say, look, this is a more structural, profound problem, and let's just call a spade, and we need to fix this more resolutely?
Well, Amir, what's your perspective on that?
Well, I think obviously, when someone's had multiple revisions, you don't want to be that person to just hop on the train and, kind of do many additional small procedures that aren't definitive. So at that point, I obviously, feel like I want to correct the deformity. If the deformity is the main problem, in my hands, I think doing a big open surgery is the best way to approach it.
Totally agree.
So when is enough enough? Is it at L2? Is it after 4 surgeries? Is there a number?
I don't know about others, but I'll tell you that it is rare for me to do a second genuine MIS deformity procedure, but that's factoring in that the single most common procedure I do for scoliosis is a 1-level foraminotomy for a patient's radicular pain syndrome. So, if we're morphing into the realm where you're actually doing MIS surgery for deformity, it's very rare for me to actually do even a second one. It's like you got one crack at it. And then when it succeeds and you buy them 5, 7, 9 years of happiness with an MIS approach, that's gorgeous. That's amazing. But the second crack at it, in my experience, doesn't lead to the promised land.
Yeah, and I would just add, when is it enough? If someone's gotten the wrong surgery 3 times, this whole kind of failed back surgery thing, then, does that really count towards, them having the appropriate procedure at any point may fix the problem. So just because they've had 5 surgeries doesn't mean that they can't get another one that would be helpful to them. But then there are people where they've had the appropriate surgery done and they may have chronic pain, and, that's the art of medicine, right?
I mean, I just, one thing that really bothers me, if I may vent here, is I love what our MIS colleagues are doing and teaching us, and I think this is visionary. It's important to know that. But when you just stay in this keyhole perspective because you're a dedicated MIS surgeon, that just drives me nuts. We're right now dealing with a patient who's had a, quote, recurrent discectomy or disc herniation. Happens to everybody. Was done MIS. There was a CSF leak, big bath full. The patient had a revision discectomy ×1 with the same tubular approach by the same surgeon. And then, quote, the 3rd time disc herniation came around, and the patient was told that they needed a PLIF done through the same MIS surgeon's approach. Again, keyhole, whatever. And when we looked at this now, there was the original disc herniation was never removed. There was a CSF leak in there. The revision discectomy, the disc looked identical. It may be recurrent, but it sure looks very similar. And then this fusion was done with basically bone graft packed upon. I don't know how they got the cage past that disc herniation. The disc herniation is still there, and there's bone graft now packed upon the neural elements in the back that required a revision. Why, at some point in time, somebody would not say, hey, this didn't work well. I'm going to do everything to repair this properly. And by the way, there's still CSF floating all over the neighborhood. Why don't you just stop here for a second and treat the pathology? Why do you stay married to this thought of, I need to do this through a keyhole to limit trauma to the patient when the problem is a flipping disc herniation, plus now a CSF leak? That kind of a boneheaded, I want to look through the world just through this. That drives me nuts.
Yeah.
Thanks for listening.
So that's a great comment. But you guys, we're getting out of time. You know, guys, know that.
The voice of.
And the other thing is in that case, I would just say that the problem was not MIS or open or whatever. It's the surgeon take a decision, and it doesn't have to deal with one or the other ones. You know, I've been through the years being a MIS surgeon getting bashed because, you know, I remember classic Chris Shaffrey picture of 3 levels lateral subsided for a deformity. I mean, and they say the MIS is bad, that they have to do all these things. But the real truth is that the surgeon who applied that MIS techniques, it was a judgment issue. You know, I mean, and then you're blaming the poor techniques, you know. So I would say you need to know when and how, as David has been saying, and everybody else. But we can spend all day talking about this, but for the sake of time, I think Koyo here is saying we need to keep moving.
All right.
Yeah, no, that was the end of the
Sounds good.
All right, Kojo, are you going to give your lecture from the back? Thank you, Amir.
Thank you, guys.